So now that we know how to locate and dilate veins, now I'm going to teach you about this grade the vein concept, this new concept, because remember, not all veins are created equal, and we want a vein that's going to tolerate the stick and the procedure. So I call it a healthy vein. What do I mean by that? Let's get into it. First of all, not all veins are created equal. Now, I want you to think, and I don't know if you've ever seen this, but certainly you can imagine it. The inferior vena cava and the superior vena cava right before they go into the heart, those are big blood vessels, and the wall is very thick. The veins out here in the hand, they're the smallest and the thinnest wall. We're going to talk about wall thickness in detail in just a minute. So vein wall thickness varies throughout the body. And then we got to deal with, what if it's already been damaged by something? And the obvious is, and for the people who are raising their hands, I wish I could see you, but I will be happy to answer your questions at the end. So if you can't remember them, write them down. But we will come back to you. All right, so a varicose vein, we all know what those look like. Well, varicosities can occur anywhere. So when that big burly guy comes in, like this weightlifter on the screen here, those veins are varicose there. That means they got loose, and that muscle wall's been stretched to the nth degree, and it won't go back. It's out and it's staying there, which means it's thin, which means it's not healthy. The chances of that rupturing when you stick it are great. So, palpate to grade. There are 4 things we want to know: firmness, which is wall thickness, size, direction, and depth. And we're going to talk about these now in detail. Firmness. Firmness is how thick the vein wall is. And in this next diagram, I'm going to give you some examples for easy understanding and comparison. Okay. In the antecubital region, visualize a tourniquet, and if you have one, that's great. Pick it up and feel how thick the wall of that tourniquet is, so to speak. On a scale of 0 to 10, that's a 6. Now, pick up a glove, but pick up one layer only. Thumb on top, index finger underneath. Feel how thin. On a scale of 0 to 10, that's a 2 for wall thickness. Now, here's what you don't know. The antecubital veins are greater than 5. It's usually 6 to 9 on a scale of 0 to 10 for wall thickness. The hand veins are the thinnest that we have. They're that too. So which one of these will tolerate a needle stick? And I usually then, I go and I get some balloons for examples. In the United States, we have something that's called the dollar store, so they're cheap. And the cheap balloon is a very thin walled balloon. Don't try to make an animal balloon, it'll rupture. If you go to the craft store, it's a much more expensive and a thicker walled balloon. So just comparing those two, which one's going to tolerate the stick better? Obviously the one with the thicker wall. So what I want you to do is, again, go back to that human, and I want you to feel the veins in the hand, and again, feather light. If you're pressing too hard and you're feeling what's ever on the other side of that vein, then you're missing the vein. So feather light, so you feel just the water balloon bounce. You'll be able to tell about wall thickness. And then come up and palpate the antecubital, and you're going to go, whoa, that's muscular. And you'll get good at grading. Then that's a judgment call on your part. Now, between the antecubital and the hand is the wrist. What you need to know about the wrist is, on every human at a specific point, and it varies from human to human, it changes from a wall thickness of less than 5, usually about a 4, to instantly a 6 or a 7. but you have to feel where that change occurs. And you must go where the wall is thicker. So palpate. You can start low with your palpation, but you need to palpate up, follow that vein till you feel that wall get thicker. That's where you would stick it. So again, I just told you about the cheap balloon versus the craft store balloon. And you want to select a healthy vein wall for your procedure. So the rule is, if that vein wall is 5 or thicker or 5 or higher, you can stick it. If it's less than 5, do not. You set yourself up for failure, for vein rupture, or for infiltration, and we don't want that. Gray is the one who also tells us that the most distal veins, the furthest out, may even be missing the layer of muscle, missing the media, which makes it really thin. So stay away from the hand. I know everybody's going hysterical at this point. Trust me, when you feel these veins and you realize you can locate them higher and they're healthier, because here's the other thing, that old adage, start low and work your way up. Well, if you start low and it fails and you have to work your way up and you end up, why would you ever start low? But without having this anatomy information, you wouldn't have the reasoning behind it. You do now. So take the science and apply it. Now, think about this. If you put a tourniquet on any one of these vessels, you're going to over distend them and the wall gets even thinner yet. So again, another reason, do not over distend that vein wall. We need to maintain the integrity of that vein, of the healthy vein. So again, the varicose vein, just want to emphasize, they can be anywhere. They can be in the hand, they can be in the antecubital, they can be in the wrist. It's up to you. Might look pretty, might look like a big vein. Palpate it. And here's the other thing. If you've got a varicosity, then palpate down to where you feel the wall get thicker, or palpate up to where you feel the wall get thick again. And that's where you stick it. Don't penetrate, don't do the venipuncture in the varicose part of that vein. So visualizing a vein with your eyes won't tell you anything. Any of these characteristics I just described for you. They won't tell you about wall thickness. They won't tell you about the integrity of the wall. And you won't really even know about the size of the vein, which means you don't know about the size of the lumen. And you need to know luminal size, because once the needle is in, there must be luminal space around that needle so blood can flow. If you pick a needle too large for the vein that you've selected and it occupies the entire vein, or a vein too small for the needle you like to use, you might be in, but your procedure will not work. And again, the vein finder tool and the ultrasound just are not going to be the tools that you need for locating healthy veins. So that's why firmness is number 1 on our grade the scale list. It doesn't matter how big a vein is. If the wall is not thick enough, you cannot stick it. So firmness is the most important criteria. Next is size. If you were target shooting, you'd rather go for the larger target. Who wouldn't? Unfortunately, you got to work with whatever size targets that patient has. So what we need to know about that target is, what size is it? Because again, determine the size of the vein. And there's a method for doing that with the vein block that I'm not covering in this webinar. So at a later date, get into that and see more detail. But the point is, determine the size of the vein and then get the appropriate size needle. And there is a way to determine that. There are analogies. direction the vein is running. So you look at a diagram, and even the diagram shows your veins go straight up and down. They can be diagonal, they can curve. And in an arm, they can tortuously move in that region. So you need to determine by feeling what direction that vein is going. So you've got room to work with. Because if you come in cross-sectional to it, you have the short diameter of the vein to work with, and you're going to try and thread a cannula into that. But if you know the direction it's going and you start at the low end of that 1 inch that you feel, then you've got room to work with. And we're going to talk about needles in the next webinar. There's a whole lot you need to know about that that's not currently taught. If you're target shooting, you're going to be more accurate if you're lined up with your target than if you're off to the side trying to hit it. So determine the direction, get directly behind it, line your needle up with it, and now we should have a successful venipuncture, successful entry. Next, depth. And again, to the participants who are raising your hands, I'm sorry I can't see you, and I will gladly answer your questions. Please put your questions either in the Q&A box or in the chat box. I'm not sure which. Try both. All right, so depth. There are 2 types of vein system in the human body. There's deep with a capital D, deep veins, and superficial veins with a capital S. We are always dealing with superficial veins, but I want to tell you about the deep vein. Deep veins run with arteries, and for every artery in the body, there's a deep vein sitting right next to it of the same name. But you would have to travel, it's beneath muscle. You would have to travel through muscle to get to that vein. Well, that's not a problem. We stick muscle all the time with shots. The problem is when you put a hole in that deep vein and you come out, a clot forms. And if that clot breaks loose, it's now called a DVT, deep vein thrombosis. When it travels to the lung, it can change its name to pulmonary embolus, or it does change its name to pulmonary embolus. We don't want any risk with thrombus formation in a deep vein. So we are always accessing superficial veins, but they come in 3 depths. I'm going to talk about that next. But superficial, think of the S. Superficial, surface sitting beneath the skin in the subcutaneous tissue. Recall the cadaver diagram. We didn't see muscle anywhere there. Okay. So the 3 depths that superficial veins come in are shallow. And this, by the way, this is a description I've given. You won't find this in any other book. I took the liberty of assigning these descriptors to this. So this is a Gail Stotler observation. But when you do a lot of palpation, I want you to keep track of the score, so to speak. When you feel those veins, do they fall into these categories, and how often? I think you're going to discover that the probability distribution curve applies very nicely here. But shallow. Not only can you easily feel it, it's like the arm we saw in the human arm in the 2 previous diagrams. It's not only palpable, it's visible. So visibly off the arm and visibly blue. Those are shallow. But only 10% of the veins, of the shallow veins, are healthy to stick. All these other blue things, 90% of them, they're not stickable. The wall's too thin or they're too small. So only 10% of shallow superveins are healthy for sticking. Next, average depth. That's this arm technically. Can't see blue, but if you were to glide, palpate, you can easily feel the vein. And by the way, there has to be a natural bend in the arm when we do this, because if you straighten the arm, it flattens the vein. That's covered in part 2 of accessing the vein with the needle. But just so you know, there has to be a natural bend in the arm for you. So rest a person's arm on the table like you saw me do in that diagram, the 2 videos before of that arm, a natural bend. The vein will be at its fullest. So average depth, 80% of the veins, healthy veins, are going to be in that group. 80% of what you and I have to stick as a healthy vein is in that group. So it's not visible to the naked eye. It's only palpable. So the first two, we glide, palpate to locate. This third group, deep with a little d versus the capital D for deep veins. The little d, superficial vein, sits deeper in the subcutaneous tissue, and that's a genetic thing. Okay, it's just nothing to do with obesity. It's all genetics. But it sits deeper. So this one, you're gonna have to press palpate. You'll glide first, you can't feel it. Now you're gonna press palpate your way across, feeling for the water balloon bounce. 10% of the veins you're gonna stick are in that group. They're a little tougher. But I have a method with this vein block and applying a tourniquet over it to describe the 3 depths. And perhaps at some point you can access the video on that to actually appreciate that and maybe experience that. So again, this is a Gale Stotler observation. Give me credit or criticize me, it doesn't matter. But this is not in any other book, and no other scientist came up with this, not to my knowledge. But take it with a grain of salt and track your own experience and see if your findings don't fall on this curve the same way. And again, the vein block can be used for that. But just know those vein blocks, the current ones, I just created one. It's not out yet though. But the current vein blocks, those wall thicknesses are not vein wall thicknesses. Those are artery wall thicknesses. So that's a misconception and it's misleading. So I don't let anybody stick this because the sensation is not the same. I use it as a palpation tool. But just know that. All right. Next. So now we know how to locate, dilate, and grade with the same palpation technique. The 21st century vein access technique for locating, dilating, and grading involved sense of touch, alcohol, and gliding or press palpating our way, feeling for long skinny water balloons. Balloons of different sizes going different directions. Once we determine wall thickness, size, direction, and depth, then we can decide if it's a vein that's going to tolerate the stick or not. If it's not, you need to keep palpating till you find one that is. Set yourself up and that patient up for success with this infusion of contrast. We don't want any contrast infiltrating out into the subcutaneous tissue. Number one, that's an injury. Number two, not all the contrast is going to where it's supposed to go. So number three, we go, that organ's not perfusing very well. Is it because it's a sick organ, or is it because half of the contrast is out in the subcutaneous tissue? So everything that we do pre-infusion of contrast impacts the infusion of contrast part of the procedure, and therefore the results, the diagnostic results, and therefore the medical outcome, because treatment is going to be determined based on those results. Also, one stick events 99% of the time with this technique. Well, you have to know the second part. First part is locating it. Second part is accessing the vein. But with this 21 CVA, we reduce multiple stick events to practically nothing. That's huge to the patient. They're already scared, traumatized, agonizing. And if their first part of that procedure is a bad experience of a multiple stick event that's painful and bruising and injuring, we haven't added to the quality of care. And we have more expense. We've had multiple tools, multiple sticks. And again, outcome. How did it affect the result? So doing this right from the first stick, even if your first stick fails, if you were gentle and we didn't create injury, number one, the patient goes, well, okay, go ahead, try again. At least you didn't hurt. Okay. But we're going to minimize all of the CCIFs that we've talked about previously. Now, let's see what this next slide shows. So locating the healthy vein means that you palpate, wet, using the pad of your dominant hand index finger, feeling for the long, skinny water balloons, knowing that the vein has an innervated muscle, and that we grade it for firmness, size, direction, and depth. You have now set yourself up for success. And again, I ask you, just try it. You have nothing to lose. If this works, you're going to be happier. The patient's going to be happier. Your institution's going to be happier. It's just a ripple effect of good outcome. If you don't like it, you don't think it works for you, continue to do what you're doing. There's no judgment on it. There's no judging. There's no grading. There's no repercussions. There's no anything with current venipuncture, the way that it's currently performed. But as this next generation comes into being and academic programs start teaching it and the next generation of people are using it, and it works, and we reduce all of those problems, then the old technique is going to be scrutinized, and there will be judgment placed against it eventually. But that's called progress. It's our duty to continue our education, add science, and advance it. Now, having said add science, I'm a vein access technologist, and you're a radiologic technologist. Your field, your discipline, compared to nursing and laboratory medicine, is the most scientific. Lab techs actually have more science education. They just don't use the science the way that X-ray techs use the science. Your field is very exact. The MA and the KV and distance and just even contrast and how it works and the tools, my goodness, the radiologic tools. Yours is the most sophisticated field, domain in the practice of medicine. And I have to tell you, the X-ray world are the kindest people in the medical profession. I recently had that experience, but with 47 years in this discipline, in the practice of medicine, I can tell you, every encounter I have personally had with radiology, but just professionally, yours is the profession that is gentle and thoughtful, and you guys want to do it right. And you do. When given the instructions, when given the science, you're ready to use it and follow it. And that's why advancing your venipuncture skill at this point in time with this science should be an easy advancement for you, an easy adjustment. Again, try it. So again, I want to remind you, because I think I forgot to tell you again, sign into the chat box. And now we're going to do the poll again. I can't think of anything else I want to add at this point. So we're going to do the poll. You're going to look at some questions and try and answer them. And let's see how much of it made an impression upon you. And don't worry about it. If it did, great. And if it didn't, you're going to go back and review this. And maybe you're at an odd, crazy hour wherever you're at, and your brain doesn't really want to have to think at this hour.